deal with some questions with Russel Rensburg, who is the director of the Rural Health Advocacy Project. Russel, good evening to you and welcome. I think let's start by sharing with our viewers what the NHI would mean for the people your organization advocates for. We've heard a lot about the criticisms and the concerns, but there are people who welcome the idea of the NHI. Share with us what you know. Russel, you're muted, so it's the horrible mute button. There we go.
There we go. 3 years into the pandemic and we still...
Press the button. Here we are. Okay, go ahead.
Yeah, thank you very much. Look, I think the NHI is not a panacea to all our challenges in the health system. All right, I think we've really had a health system that's been declined for a number of years, and just introducing the National Health Insurance Fund on its own will not address all of those ails. But the principle around which the NHI is established, or the NHI fund is established, is really an opportunity for us to examine what worked well and what didn't work well over the last 30 years since the democratization of the South African health system. So as we understand it, the bill proposes the establishment of a fund where all public sector funding will be consolidated and then distributed to facilities at the district, and then directly to provincial hospitals, tertiary hospitals, and central hospitals will all receive their money directly, or their budget directly, from the NHI fund. The role of the provinces would then be to coordinate the delivery of healthcare services by ensuring that there are sufficient HR and so forth and etc. How is this different from the existing system? You know, South Africa inherited quite a complex health system with over 600 hospitals and over 3,000 clinics. But when it comes to our health outcomes, and we talk about universal health coverage, we're talking about those essential health services like access to reproductive health care services, access to treatment for HIV and TB, and beginning to address the onset of non-communicable diseases like diabetes and hypertension. At the moment, the way the funding arrangements work, a lot of the money that we currently spend in the public sector on healthcare is absorbed in hospitals, leaving very little money for our district health systems where the greatest need is. So under the NHI, we like the idea that rural systems will get money directly and will be able to determine their priorities at the local level and address particular health threats in their spaces to ensure better healthcare for rural communities overall. At least that's the theory.
Yeah, thanks for that. And I think you make a lot of sense out of, you know, what tends to come over as really complex medical architecture in what it would look like once the NHI is implemented. But it does raise the two questions, really, Russel. The one is around experimentation. It would be too late for us. I mean, we're going to be live experimenting something that would already be in existence. And, you know, how would we manage that, especially if some of the changes we need to make would be massive for the South African context, given that we're using a lot of our modeling based on international examples where, you know, maybe unemployment, for example, wouldn't be the same as exponential as it is in South Africa. But leave that aside for a moment. If there's time, we'll come back to that. Let's talk about the standardization of the hospitals. You see, some hospitals are in a terrible state of disrepair due to the under-resourcing and underfunding, and you know, I'm not talking about the private hospitals here. How would they all be brought up to one standard? Or let's say, if the benchmark is private hospitals, brought up to that standard in the system, so that Hospital A is the same as Hospital B in the Northern Cape, in KZN, wherever?
Well, I suppose part of what they do is to define the different levels of care, which is already well defined in the National Health Act. And I think the National Department has already established norms and standards, which all of these hospitals have to maintain. But in the NHI proposals, they reorganize the care system. So at the first level, and I think part of the first phase is to strengthen primary health care up to the district hospital level. So that's ensuring that essential health services are available, that we improve the efficiency of hospitals. You know, like one of the challenges that we face at the moment, because clinics often don't have all the services that people need, you know, we find that people are accessing primary healthcare services at hospital levels. So the cost of delivering those services is almost 3 or 4 times higher when delivered in a hospital. So when we start looking and standardizing care, we start firstly with the things that we want to improve. So to improve maternal and child health, we have to improve the availability of staff at the primary healthcare level. We have to ensure that there's greater engagement with the community through the deployment of community health workers and outreach teams. And ultimately, we have to ensure that people are able to meet the most basic healthcare needs. So to some extent, we must make doctors available either through integrated practices, as well as to ensure that essential medicines are consistently available. If those aren't available at primary healthcare, then you find that your hospital will be doing a lot of those services, leaving less capacity to deal with more acute health situations that require hospitalization, particularly like giving birth and so forth. So I think the first thing is to start with the information, to understand what our production and performance is at the moment, and then determining our responses based on that data. And when you have a little bit of autonomy at the district level, or even at the sub-district level to do that, you can design your local systems to respond better to local need. But I think the framework is there. I think now we're just creating an environment to put that accountability more on the service provision rather than just the politics, which is an important component of that.
So this customization would help us create a more effective healthcare system. If you've got a big, for example, diabetes or whatever, problem A in geography A, it can be done, in a way that is efficacious, whereas another place might not have the same problem, allows themselves to focus on solving for something different. So I understand that and I get that. One of the big concerns is around HR. It's around whether, for doctors, whether they would have the autonomy to charge the rate that they think they are worth, and suddenly being sausaged into a system where there would be, and you can answer this for us, a standardization of rates?
I think it's very difficult to standardize rates because I think even in the current medical scheme environments, and you will probably experience this, some doctors will charge more than the medical scheme is willing to pay, and you would be required to make a co-payment, right? And even within the existing medical schemes framework, you'll find that, let's say if we take Joburg as an example, the rates charged in Randburg or in the north of Johannesburg are significantly higher than the rates that can be achieved by doctors practicing in poorer areas with lower medical scheme penetration, where often the consultation fee can be anything between 300 and 400 Rand, whereas in more established areas with higher medical scheme penetration, those doctors can command anything between 600 and 800 Rand per consultation. So I think these inequalities in terms of the kind of fees that they can raise already exist in the system. But I think the opportunity with having a public system that is able to bring in additional capacity is that we can actually widen the net of opportunity for healthcare professionals by creating resource envelopes in areas where they wouldn't normally practice, particularly in the rural areas where they have very low medical scheme concentration. So it's not very attractive for private practitioners to operate in those spaces because there aren't enough clients to sustain their practices. But through things like, in theory, like the contracting units for primary care, you can actually create contracts to have doctors servicing a network of clinics in an integrated way, and in that way attract more professionals to rural areas.
This is such an important point. Russel, so sorry to interject you. I hope that you were rounding off your point, but I want to pick up on what you're saying. It's very important, and that's why it's so, I think, critical in the public interest to have a nuance and a really, kind of diverse conversation about this. Because the scenario that you've just described sounds to me like it's creating more opportunities for doctors in the healthcare system in South Africa, particularly those in private healthcare who are concerned that their prospects would be diminished under the NHI. You're saying actually there'll be a bigger population for them to service, and so they should be able to make more money, and in a co-payment environment, they would be able to, I suppose, in some ways, charge the rates that they want to. So just confirm if I've understood that correctly. But the question I'm asking is, why has it been presented, do you think, in the public domain as something scary for doctors? We talked about a skills flight, medical professionals leaving the country, going to other shores, because this would be an untenable situation for them.
Well, I suppose it's a very controversial point, because any kind of change or any change to the status quo brings with it certain levels of uncertainty and affects different portions of the population in different ways, right? I think a lot of the fear around the bill at the moment is its long-term ambitions rather than what it will do now, right? So in an environment with the private healthcare sector, and I'm not blame shifting to the private health sector, but it's very lucrative. It's worth more than 260 billion Rand a year. right? It's serviced by a large network of private practitioners. And in the status quo, they do a very good job in delivering healthcare. But when you introduce a policy that seeks to undermine the sustainability of that business over the longer term, it does create some anxieties. So I think until we have more information and we start seeing this process unfold, I think the uncertainties will decline. I think I'm old enough to remember when we transitioned to democracy. And up to 1994, we were similar threats around immigration, food stockouts, people
Capital flight.
Capital flight. And 30 years later, we're still an imperfect country, but we continue. But change is always a difficult process. And I think part of the job that the government needs to do is start engaging these groups more directly around how some of their fears can be alleviated and how they fit into the bigger picture. Because in the current policy design, all we have is a broad framework with the establishment of the NHI fund. And a lot of the details that will be rolled out under Section 59, which are the transition arrangements, are things that still need to happen. And until those things begin to happen, I think we'll continue to have some of these anxieties in the system. But I think the government themselves have said that they estimate that it would take anything up to 14 years to fully complete these reforms. Others may feel that it may take even longer, but it's a process rather than anything.
Yeah. Well, thank you very much for sharing your insight and your perspective on this bill and helping us to make sense of what we're confronted with.